So this is a very actual and important question. In fact, during the last few years, the checkpoint inhibitors changed radically the treatment of Hodgkin lymphoma. Since their approval is just for a patient who already failed standard chemotherapy, autologous transplantation, and brentuximab vedotin, we currently don't know if such patients should be consolidated with an allogeneic transplantation after that they have been treated with the checkpoint inhibitors. We do know that the response to checkpoint inhibitors for some patients could last for years. But we do also know that many patients could have a relapse even if they had a response to checkpoint inhibitors. So generally, if a patient could receive an allogeneic transplant and is a potential candidate for it, the majority of centers are strongly recommended to go on and proceed with the allogeneic transplantation. Of course, we do know in 2022 that such therapies could increase the risk of immunological toxicities. In fact, the checkpoint inhibitors are a class of drugs that actually they are increasing the immune system, not just against the tumor, but in general. They release the brake, as the Nobel Prize, which discover such a class of drugs, are usually saying at congresses. So if we imagine that after an allogeneic transplantation, we are expecting a higher incidence of immunological complication. I'm referring especially to acute GvHD, but also chronic GvHD. It is expected that those patients received before allogeneic transplantation checkpoint inhibitors could have more immunological complication. In fact, this slightly increased incidence of acute GvHD and also in some cases febrile syndrome, which was not properly defined as acute GvHD, but it was related to the immunological complication, were described in the first patient treated with checkpoint inhibitors and then allogeneic transplant. During the last years, some recommendation made from experts in the field have recommended to wait a reasonable interval of time between the last administration of checkpoint inhibitors and transplant. They are referring to 5 to 6 weeks, even though this time interval is not well defined, and also there are no so much data supporting this hypothesis. But considering the half-life of checkpoint inhibitors that we are using, it is considered a reasonable interval of time. And also it is suggested to trying to apply all the methods that we have to reduce acute GvHD incidence. I'm referring to the use of a reduced intensity conditioning regimen, first of all, trying to use the donor who shares the HLA match, the higher HLA matching with the recipient, and also use a bone marrow graft in case that the center is complying with such procedures and has experience in it. So these are the current suggestions. And of course, there is also another situation that we should consider: the use of checkpoint inhibitors in case of a relapse of Hodgkin lymphoma after allogeneic transplantation. So we do know that using such a type of drugs after allogeneic transplantation, it is an effective treatment, even if the patient has received them before. But actually having a new immune system, we could trying a so-called re-challenge with checkpoint inhibitors, and it has been shown that it could have a higher efficacy than other standard treatments. But also here it has been observed and reported an increased incidence of immunological complication, namely acute GvHD flares, or also chronic GvHD flares, or a new episode of chronic GvHD. So also in this case, it is recommended at international level that we should, in case that we think that checkpoint inhibitors represent a good strategy for the relapse after allogeneic transplantation, the thing that we should do and the safer thing that we could do for our patient is starting with a reduced dose. And then if the patient within the first cycles of therapy does not develop any immunological complication, then we could progressively increase the dose. And these are what we know right now, even though there are still many things that we should discover, from an immunological point of view.